Dr. Curtis grew up on his family's ranch in the small East Texas town of Wills Point, where his family have been active members of the community for over 100 years. That's fantastic. He and his wife are high school sweethearts and have three beautiful children. I've seen photos, so I can verify all of that. Dr. Curtis is a diehard Texas A&M Aggies fan. I think that's Gig'em.
Okay.
I believe if I'm up on my Texas football, and he
Yeah.
attended Baylor College of Dentistry and did his pediatric dental residency there. He earned the prestigious AAPD Harris Fellowship for his research to improve advocacy efforts for our nation's children, which I think is terrific. Dr. Curtis is a board certified pediatric dentist and on staff at Children's Medical Center in Dallas. In his spare time, he enjoys spending time with his family. I'm going to insert going to Disney World because I know that's a big thing for he and his family as it is for us and being a dad. So there it is. So with that being said, it's my pleasure to introduce one of my favorite and our most popular speakers, Dr. Ben Curtis. Dr. Curtis, take it away.
Good evening, everybody. I am really happy to be back again talking to y'all this evening. And as always, I've got a lot of stuff to make it through, and we don't have a lot of time here to make it. But please make sure that you put your questions in the Q&A, and I'll do my best to get to those. And I'm always happy at the end to have the rest of them emailed if I didn't get to it and try to reply back to you. Our topic for this evening is going to be lumps and bumps, oh my, the successful removal of pediatric soft tissue pathology with an all-tissue laser. So who am I? Got that brief introduction there. But more importantly, who am I really? So here's my post-COVID, I need coffee and I've got Christmas masks and hats on. So it's great to reach out to me via Facebook or Instagram. I'm pretty active on both of those. So if you really need to reach me or more questions or more info and stuff, I post cases on there too as well. So it's a great resource to reach me. There I go again. But more importantly, I'm a dad. These are my three kids. My youngest is Birdie, or my oldest is Birdie, middle one Dotson, and the youngest is Emerson there. So that's our Merry Christmas picture for this year. I'm a board certified pediatric dentist, as he said, did my dental school at Baylor. This is one of my buddies from dental school. He gave his first injection to me and I got blood. So pretty exciting memory there. I still am at Children's here in Dallas at the hospital. And as you said, I did a Harris Fellowship with the American Academy of Pediatric Dentistry. And I am in private practice here in Dallas, Texas, where I utilize the BioLace I Plus laser pretty much every day in some form or fashion within my private practice here. And we'll talk about the soft tissue component of that utilization today. Disclosure, I am an advisor and work really closely with BioLace on developing products. They'll send me things to trial or ask my feedback on different things from a clinician standpoint. And I also do a lot of speaking and training such as this or hands-on courses, or I'm involved a lot with the educational side of just doing a lot of laser training. During the COVID shutdown, I did a lot of resident courses for the residents across the nation for their pediatric courses. So that was really fun to be able to utilize that downtime for an educational manner. So pretty passionate about that. The laser we're going to talk about today and utilizing is going to be an all-tissue laser, and it's an erbium laser. That's an important factor to remember when we're considering lasers, and this is the BioLace Waterlace I Plus laser is the formal name for it, and we can use it both for soft tissue things such as frenectomies, gingivectomies, soft tissue pathology, which will be our hot topic for today, and also hard tissue as well, which is another love of mine with this laser, is to be able to do fillings and crowns without having to do injections. So it's pretty fascinating as far as that goes. One of the interesting things I always like to touch on when we're talking about this laser in particular is how it works. It works by basically ablating the tissue. So when we're looking at soft tissue, the Waterlace only affects about 5 to 10 cell layers, where if we're going to be using like an electrosurge, it's going to affect 1,000 to 1,500 cell layers, and a scalpel will affect about 100 to 300 cell layers. How does that translate to us? That translates to us in inflammation, pain, and healing. The less cell layers you affect, the less inflammation you're going to get. If you don't escalate that inflammation cascade, if we think back to our biology days of the basic core biomedical science there, if we're not inducing inflammation, we're going to have less pain issues and better post-operative healing. And so with the laser, particularly this Waterlace laser, the way it's designed to work, it's only affecting a very small layer of those cells. So for soft tissue things, it works really great. just kind of what are we going to be talking about today? We'll identify common pediatric soft tissue pathology things and identify what might you want to consider treating and what might you want to refer out. So that's always an important thing for us as clinicians to decide what you're comfortable with. We'll kind of talk through the thought of that. We'll walk through the step-by-step process of doing these procedures. So the excision of that soft tissue lesion, really important thing there. And then the post-operative care and how we kind of handle that, and also making sure that we're documenting appropriately and billing appropriately. So we want to make sure we cover that side of it too. That's a really important factor there as well. So soft tissue things we'll talk about. We're going to address mucous seals, which is by far one of my most favorite procedures in all the realm of pediatric dentistry is mucous seal removal. I would have never thought I would have said that. And honestly, I would not have ever done it if it wasn't for this laser. And I have them referred to me from friends of mine to do these and things like that. And I help colleagues of mine do them and learn to do them. So it's a really great procedure and a really great service to your patients, not to have to refer these out, but to be able to do them for yourself. And it's a really great patient rapport builder too. So I love the mucus seals. A lot of times we see those in our toddlers. Fibroma removal, you don't get a ton of these, but every now and then you'll find one. Veruca, the warts. So those always give you the heebie-jeebies, but we can address those too with this laser. And then ulcers, we can also touch on ulcers too for kids that are having issues with that or adolescents and things. Sometimes ulcers can be a big problem for some kids, and we can address that today. We'll talk about. So let's dive straight on into mucus seals, my favorite. So this is one mucus seal, 3 different images of one mucus seal. It is giant, y'all. That is one big mucus seal. And it just makes you kind of go, ooh, wow, okay, what are we going to tackle with this? And so let's move on here. Yeah, dang, okay. Oh, so let's walk through step by step with the laser screen. So we're going to kind of take it from start to finish here through a case. And so on the laser in particular, this is the home screen. So it's got a touch screen with it. And so literally all you do is touch the soft tissue button on the home screen. Then we can go to gingivectomy setting, a frenectomy setting, and a biopsy setting. So we'll click biopsy for this one since we're going to be removing something. And then within it, it's got rapid cut settings, smooth cut settings, and smoothing. And we've got different settings down through here. I love the rapid cut. I pretty much use the rapid cut setting for all of my soft tissue removals. So with it be the mucus seal, the fibroma, or the Veruca, I like to use this biopsy rapid cut. I also really like to put the 5Z or the MZ5 tip on there. There's different tips that you'll have in your armamentarium there that you can choose from. And I really like the 5 tip for this. These are the factory pre-settings. So this laser is really user-friendly because all you do is click the button and it's preset for you specifically for what you need it to do. So here's the watts, the hertz, the water, and the air is already pre-calibrated for you for the most ideal thing for this procedure. So I don't even mess with it. So that's one of the great things I love about this department for sure. So this is our mucus seal here. So we're looking within the lower lip, which is the most common area to find a mucus seal. It's within the lower lip region down here. And this one's probably going to be about 3 millimeters in diameter there. We're taking the laser and we're going circumferentially around it. So basically you're going all the way around the edge of it on that rapid cut setting, basically forming a little trough around it. This is fluid filled at this point. Sometimes they have fluid in them and sometimes they don't. They're like little deflated balloons. It doesn't matter if you pop it while you're taking it out, it'll still come out just fine. So don't feel the pressure to remove it intact, okay? If it pops, you'll still get it out just fine. And then once we've kind of troughed around it, we'll come from one edge and basically envelope flap it upward by grabbing onto it with some cotton pliers and pulling up. You'll need an assistant to hold part of the lip and you'll hold part of the lip to keep it taut. And then you'll be holding the laser in one hand and the assistant will hold the cotton pliers in the other, or you've got cotton pliers and the laser and the assistant holds the lip. So those are kind of the 2 tactics here within this to make sure that we're getting a good hold on the on the mucous seal, and we're just walking back underneath it as you're gently holding it upward. Once you remove it out of there, we're going to go back to the biopsy screen. And as opposed to the rapid cut, there's going to be a laser bandage setting on there too. Once again, it's already preset for you. And what the laser bandage does is it helps to basically put a thin keratinized layer on the outside of the little wound, or the surgical area, as I like to call it, the surgical site. And it helps to basically keep it from wanting to bleed as much, and helps it want to heal a little bit better. You can see we're not having any bleeding at all, in particular with this removal. Pretty impressive. You just cut that thing off of there and it's not bleeding. Why does it do that? It's because how the laser works. If you took a scalpel to that, it would be bleeding like crazy. So this is what it looks like when you finish with the laser bandage for this one. Ah, yay, over here. You're done. It's that simple. The whole procedure takes about 5 minutes. And that's why it's one of my most favorite procedures to do, is because it's simple. It's really easy to do, a short amount of time. So it's easy for the patient, and it's so rewarding. You got to cut this off of there and it's going to heal great. So let's walk through this ginormous case. I think this is a really good one to see, because if you saw this one, this might be one that you didn't want to be your first one, okay? So I can't feel my face when I'm with you. So do you numb these or do you not numb these? That's a question there. I normally am gonna numb just a little bit around the edges of these, okay? So if I go back to this page, I would be just putting a little bit of numbing here, here, and maybe over here, just a little bit of local around it after I put topical on. So I'll put topical and then do a small injection. They normally don't feel anything with that. The reason I numb is because if you just put topical, you could make your trough and start the envelope, but then you're gonna have to put more topical underneath it. It just takes a little bit more time. And I find that it doesn't make my kids tolerate the injection really well, and I'm only having to give a small amount. So I actually prefer to numb for these, just a little bit of lidocaine. So this is what it looks like when you get done. That's a giant hole. It looks really big. When I took this one off, the lip was kind of deflated in the area, and you kind of are like, ooh, geez, is that okay? And the question to that, or the answer to that question, will come in a few slides. But when you leave a hole that large, you think, do I need to suture this closed? No, we don't suture. We leave this open. This is not gushing blood. It is perfectly fine and clean. The other thing I want you to notice is this little ball right here. That's the salivary gland. It's a second salivary gland, and it was removed too. When you remove these, they're not all clean. Sometimes there's these little fingers of salivary glands that are around the area. You want to remove those too, okay? Those are important to get that out of there, because that's going to reduce the risk for recurrence, okay? Well, that escalated quickly. That became a very big hole really quick. And so you want to be prepared for making sure that they come back for a follow-up, okay? All of my soft tissue removals, I have them come back for a 2-week follow-up. In about 2 weeks, they magically heal. That giant hole went from this to this in 2 weeks. Impressive, okay? Your staff is always amazed when this happens. The parents are amazed when you show them the pre-op, the post-treatment, and now they come in for this. And we always show them the pictures. And it's amazing how great these heal without stitches. It's really impressive. And it's all because of how that laser works. Whew, what a relief, right? Here's another great case, and I like to compare it here as we go across. And so what we're going to see here is was the small mucus seal. We removed it, and it looks a lot bigger here than was here. So when we were taking this out, there were some secondary salivary glands underneath there that we had to remove as well. And that's why it looks larger here than what we might have anticipated initially from there. Really important to prepare the parents for that, because they're going to expect this tiny little hole and you're going to have a bigger one. And then it magically heals, and you'll see right here, there's just the little last part of how it healed by secondary intent. So it closes itself back up, as opposed to with a suture, if you stitched this, it would close by primary intention, but you don't need to do that. It'll heal just fine on its own. So here's another really big one here that's been on this lip for a while. And this was a little bloodier, okay? You'll notice how this one has a lot more bleeding around here. You can even see how we're getting some bleeding back through here. If when we're removing this that you're noticing more bleeding like this, you can always go in and do another a little bit more of an injection of lidocaine with epinephrine, and that epi is going to help get a little bit more hemostasis in there. Or you can just go over the area with a laser bandage to kind of help that bleeding there a little bit more. But definitely what we're seeing here is how large this is, and then we're getting deeper in this area, okay? The longer that this mucous seal goes, the more likely it is to grow deeper within the tissue. So if it's only been there a month, it's going to probably be much more superficial. But the longer that mucus seal goes with the kid chewing on it, let's say it's been there 6 months and it grows deeper and deeper and deeper, we're going to have to go down deeper and deeper and deeper to get that. So when we're thinking about, do I want to treat this or refer out? If that thing's been there for 6 months to a year, that may not be one you want to start with, because you may be going a lot deeper down within there, because they kind of grow roots, if you want to think about it like that, that you're going to have to remove to make sure. This is what it looked like when we took it out, was this ball. So it actually came out in this gnarly ball as like a squishy little balloon. They're not always that. Sometimes they're this hard kind of scarish tissue there, and that's why they need to be removed. Here's a fourth case here where we're seeing a smaller one, kind of a side angle and a front angle. Once again, we're removing it here, and a little bit more bleeding than we've seen in some other cases, but still not a lot of bleeding. And I don't worry about that amount of blood. That's a good blood. It's healthy blood. It's not an infected blood. It's okay for that to be there. And this is what it looks like at the 2-week post-op. You'll see it's not quite done healing yet. Why did this one not heal completely in 2 weeks, but the larger one healed so much better in a 2-week time frame? Everybody's different. And that's what I like to preach to my parents all the time. I can't compare what this kid in this room is going to have to that kid in that room. Each child's needs are different and specifically to them, as is their outcomes here. So we don't know how that kid's body is going to precisely heal, but we know what the norm is. And this is still really normal for this to still be slightly closing by that secondary intention and to have a small little fibrin film over that area. In another week, it'll be completely healed. So they're a 3-week healer, not a 2-week. So what do we consider when we're thinking about treating these mucus seals or referring these mucus seals out? Number one is location for me. The most common is the lip. That's really easy. Sometimes we can get them in the tongue, underneath the tongue. If that's really close to one of those big blood vessels, you might worry more about removing that and want to send that one out, maybe to oral surgery. But most of the time on the tongue, they're very superficial. They don't tend to go deep like they do in the lip. Sometimes you can get them along the palate. Remember, a mucus seal is just a ruptured salivary gland. So anywhere you've got the secondary salivary glands, you can get a mucus seal. And so maybe you might not want to dive into the soft palate region back there. It's a little gaggy in that region. The history, how long has it been there? Like I was saying, the longer it's there, the deeper it goes. So if we've got a case where we're wondering, if it's just been there a month, that might be a better one for you to start on, just so you can feel better about it. The longer they've been there, like I said, I've had some that have been there for a couple of years on some teenagers, and they get pretty gnarly really quick. If they're firm or soft, the firmer they are, kind of like that ball I showed, that was really firm, where the soft ones are going to be more those fluid-filled ones. A big one versus a little one. Maybe you're not going to feel comfortable right out of the bat with having that big hole in the lip. That may make you nervous. It still makes me nervous, but it still heals just fine. So just things to think about for you personally, and when you want to try to remove these, whether or not you feel comfortable with those. Those are kind of my logic, I think, through when I'm doing these. Let's take a look at some fibromas. Here's some research articles on fibromas finding that the erbium, so this is just the abbreviation for the laser, saying that the erbium laser appears to have less traumatic effect to the target tissue and offers an improved postoperative healing. Well, that's just what we were seeing with the mucus seals, that you get such good postoperative healing and it's way less traumatic. If we think back to that initial diagram I showed with the cell layer necrosis, this is exactly what that image is showing us. There's such little trauma to the tissue. It helps it heal so well. Here's another article that was published talking about effective hemostasis achieved with these and how it allows the precise surgical ablation, just a fancy way to say removing it, with minimal thermal damage to the adjacent tissue. And so overall, that's really going to help you get better results in the end than if you were just doing it with a scalpel or a pair of scissors, okay? And that's exactly what these cases are showing, and I found as well. As we're kind of walking through this here, I'll kind of go a little more quickly through this. It's the same process. Like I said, we'd click on the soft tissue setting, we'd go to biopsy and touch that screen. We're looking to make sure we've got the proper tip on here. We've got our settings, and I love the rapid cut, like I said. And then we've also got our laser bandage setting in there as well. Here is a fibroma that had been in this child's roof of their mouth off and on for several months now. The child really hadn't paid too much attention to it, but they had noted that it had been there. And to them, they weren't too sure that it was growing in size. And so we sent them home to talk about it with the parents. And the parents were kind of debating that. And then they felt like they did notice that it was growing a little bit more in size and they wanted it removed. So this is looking at more of the hard palate. The soft palate doesn't start until back here, past this area. And so we're all in the firm hard palate region here. And this was a very firm hard ball. So not squishy. So we were sure this probably wasn't a mucous seal, but we're more in the provisional diagnosis of a fibroma, okay? When we remove this, you remove it exactly the same way as you did when you removed the mucus seal. You start with the cotton pliers on the edge of it, or you start going circumferentially around the edge of it, then put the cotton pliers on the edge and lift up. And then we just kind of peel it back, going right under the edge of it. And then bada bing, bada boom, here we are down to the periosteum, down through here, just a little bleeding around the edge, very minimum. Okay, we would not expect for this to have more of a crater or a large divot in the roof of the mouth. Sometimes when we're involving this more taut, tighter, firm tissue, we might see a little bit more of a defect there than in the full mucosal of the lip. So I'd be bracing the parent that the child may notice a little bit more of a ridge there or a cavitation in the soft tissue that their tongue may feel, but that's totally normal and with time will subside. So with this one, we would anticipate a little bit more of a defect, if you wanted to call it that there, that'll heal a little bit longer with time till that smooths out. When we're working here on the roof of the mouth, it's kind of hard to get a good isolation back through here. So you could put in an isolite if you wanted or some gauze, but the big thing is you don't want to drop that, okay? So we want to make sure the firm ones sometimes are a little harder to grab onto. And so we've got to make sure that we've got a good hold and we've got good isolation so that they're not eating it or inhaling it, okay? Both are two important pro tips, as I like to call it. I'll give you some of my words of wisdom there. So, to treat or to refer, what am I thinking about with these? So aesthetic regions, sometimes fibroma, which is really probably that kid shoved something on the roof of his mouth and irritated it. You know, it's obvious that they hadn't had orthodontics yet, but sometimes the ortho appliances like a Nance or a palatal expander may be rubbing in this area and induce one of these fibromas. Pretty rare overall to get a fibroma, but most of the time it was due to some sort of trauma. Maybe a piece of food got stuck there and jabbed them, or maybe the pencil. It's really common for kids to be having pencils and get a piece of pencil lead or something stuck in there. So location is really important once again. Is it more of a vascular area? The fibroma itself should not be vascular. It's going to be more firm fibrous tissue. So it itself should not really have a lot of vascularity, but it could end up in a vascular region. And so we always want to be conscious of not just the anatomy of the thing we're biopsying, but also conscious of the anatomy surrounding that. Once again, a good thorough history is going to always let us know, do we need to monitor this or do we need to remove this? With the mucous seals, if we kind of step back to that, I normally like for them to be conscious that it's been there for a month. So if they're coming into me and they haven't, oh, I didn't know that was there, doctor, I'm normally having them monitor it for a month and coming back and seeing what it looks like in a month. If they've known that it's been there, most of them know that that's been there and it's something that the kid chews on and plays with. Same things with these fibromas. They tend to know that is there and it's something that the kid plays with, messes with, and distracts them. So the parents tend to know a little bit more about these, and that's going to let you know kind of more of the documentation to make sure that we can recommend the removal of that and then it won't resolve on its own. Okay, so if they've been there longer than a month, most of the time they will not resolve on their own. So, ooh, Veruca vulgaris, everyone's favorite. Dun dun dun. Said no one ever. Ah, so my son is really into Home Alone, my middle one, Dotson, and this is his favorite part of the movie is there, and he walks around the house screaming that. So that instantly comes to mind for me when I think of Veruca. We have to remember what the Veruca is. It is a virus. It's a wart, okay? And so it's really important that we are making sure we remove this appropriately, okay? When we're looking at a fibroma or a mucus seal, that is non-pathologic and disease state. It's just traumatized tissue. It's a natural response to that. This is more of a viral disease state, if you want to think about it like that. And so when we're removing this circumferentially around the edges, you're going to produce aerosol. So we need to make sure we're being conscious of that and that we're holding the high-speed suction directly over the area as we're going around, okay? That way we're sucking up a lot of that aerosol, okay? Within the AAPD reference manual, so the Pediatric Dentistry Bible, if you want to call it that, it has a section on lasers and it talks about specifically Veruca in there. And it talks about case study where, you know, the concern can be with these is that aerosol that you're breathing in the viral state of warts, okay? And so we want to make sure that we are treating that appropriately. To my knowledge, there has not ever been any formally confirmed cases of that. It's just more of a suspicion and a concern there, particularly during our aerosol conscious times now within the last year. I really wanted to make sure that was a drive home point for y'all that we're being conscious of that when we're treating a Veruca. I do treat these, but some people don't feel comfortable with that, and that's okay. You have to have your own comfort level. And if you don't feel comfortable about these, you still have to do something about it. You have to serve your patient with that. So we have to find someone that can remove these because we're not anticipating these to go away. And we are anticipating that they could spread to other areas. So it's really important that we make sure that we're treating these. The other thing that always comes to mind when I'm thinking about a Veruca in the mouth is that they got it from somewhere, which is normally their fingers, because children are always putting their fingers in their mouths or putting things in their mouth. So it's not uncommon for them to have picked this up at daycare or preschool by putting toys in their mouths. And they may have one on their finger that they chew on, or they suck their finger and they've self-inoculated themselves in their mouth. So when we've identified one of these in a child's mouth, I'm always making sure to tell the parent that if they've got one on the finger, you need to get that removed. And then I'm going to remove the one in the mouth. I don't want to remove the one in the mouth, then the child re-inoculate themselves and they get another one. So we need to treat these Veruca wherever they are on the body, not just the oral cavity. So it's imperative that you're asking, do you have these other places? And mainly the hands is our main concern there, okay? When I have a patient coming in to see me for recall, that's one of the things I'm always glancing at from head to toe. How are they looking overall? And I'm always checking the hands of those toddlers, just glancing at them. And if I notice that they do have a wart on their fingers or hands, that's a really common thing of childhood. And we want to make sure that the parent is aware that the child could spread that other places on their body and could spread that into their mouth. So that's just a systemic health concern for you as a provider and what we're serving for kids that really is imperative for us to discuss. So a little aside when it comes to Verucas to make sure that we're being overall conscious of that for our patient's best interest. So here's a case that I had. It kind of looks like a brain almost. So you'll see that it has a plaquey, filmy layer over the top of it there. When you dry it off, it had the classic little fingering look of it that is oh so creepy, if you want to say. And this one is in an interdental papilla in the posterior. So an interesting location for removal, okay? And these are two primary teeth here. So, ooh, good luck with that, right? So the Veruca always seem to come up in the weirdest locations. And so the Mucous Seal is in a pretty ideal spot, but these Veruca are always strange positions, it seems like. And so you really want to make sure you feel comfortable removing it, but also comfortable with the location of it. And I felt really good about this one because it was in between two primary teeth. So even if I removed part of the papilla and we ended up with a defect back here in the back, I know that that is going to be lost and recontoured because this is all primary dentition. So a minor defect now in primary teeth world is not going to make an overall long defect for the life of that child. And so that's something you want to be conscious of too. If these were adult teeth, were we anticipating perhaps to have a defect, which there really wasn't one in the end, which is good, then we might want to consider referring that to perio, okay, to our friends over in periodontal world. What I want you to notice here is the difference. Sorry, I don't have a more zoomed out view of this, but the crust of this papilla is coming up well over the contact. So food and stuff can get stuck underneath this. So this definitely increases the caries risk in this area and the gingival risk for irritation and food impaction. So minus the wart alone and the disease state of that tissue that is not going to resolve, we also need to do it for the health of the teeth as well. So we're going to look at this huge amount of tissue. It's imperative that we prepare the parents that this is going to look a lot different when we get done with this. So this tissue is not going to return to this state, nor do we want it to. We need to remove this back so healthy tissue can resolve. I love how this isn't bleeding, okay? Like this looks great afterwards. If I was to take a scalpel and cut that off, that would be bleeding a lot. But the way the laser works, it does such a good job to help control the bleeding and really help healthy tissue remain. So once again, a 2-week follow-up here, and look how healthy that tissue is, and it didn't recur. So that's a great thing there with a Veruca. Once again, this is my pro tip. I've kind of already got on my soapbox for this one, but it's important that you're remembering that we have to have that high-speed section over that area and that we're making sure that we're doing a good job of keeping that aerosol under control. The other thing to think about too with this is technically the laser and how it works is it's incinerating those. It's blasting them away. It heats up the tissue to a boiling point. It expands and it combusts the tissue. It's basically denaturing the tissue and anything in the tissue. So thus any true particles or the laser plume should technically be dead. So it's a dead virus aerosol. So it's not a live aerosol like it would be if you were polishing or cutting on a tooth with a handpiece. This is a much different aerosol that you're producing that's having technically dead particles within it. And so the infectious state of that is going to be much different than it would be if it was a live viral particle. Once again, there's not hardly any research or cases or things to document either that. This is just a scientific understanding of the basis of that, which is kind of where my comfort level with these comes from. Once again, treating or referring, I think the number one thing is, do you feel comfortable with a Veruca? The next thing is the location. They can end up, like I said, in the weirdest spots. And so we want to make sure if it's in, I've had one on a soft palate before. I do not like to treat things on the soft palate because it's going to be a gagging risk. I don't want to be spraying air and water and stuff down their throat. How am I going to isolate that well for them too? Am I going to be able to put gauze back that far with them awake? Most likely not, okay? And so normally for those, I'm referring them over to the oral surgeon to have that assessed and removed there, okay? The history, how long has it been there? Does it have a stalk on it? So can you palpate it? Sometimes the Veruca are spread out. Sometimes they almost have like a little stalk underneath them as well. How big are they is always an important thing to consider when we're treating or referring these. I've referred out several of these that are more in the anterior region, just around the gums. It seems to be a common spot for them to settle in is in that papillar area. I don't like to treat them in the anterior on adult teeth regions for the very reason of the concern of a defect. You know, it's pretty much unavoidable, but my friends in perio are going to be a lot better managing a more cosmetic gingival situation than I would. Of course, if we don't have those options around you, I'm in Dallas and there's a lot of specialists in our area. So it doesn't make sense for me to treat that if I could refer it out to someone that I know it would be better hands doing it for the patient. If I was in a more rural area, it would probably be a great service for you to provide that for them as opposed to them driving hours. And as long as they understand kind of the post-operative concerns that we just can't control everything. Let's talk about ulcers. You know, we probably have kids every single week in the office with ulcers. I myself get ulcers. I just had 2 last month. And so I struggle with these as well. So sometimes this can be a really great service to your patients. So we can go into a couple of areas here to do this. We can go into the expanded area on the home screen, click on that, which will take you directly to the laser bandage setting. So we want to use a laser bandage to treat this. Once again, what the laser bandage is doing is putting a thin keratinized film, and it's basically promoting healing. It's that concept of kind of utilizing a low level laser therapy there. So you're using a positive energy. So you're helping to keratinize the outer layer, which is going to help make it a little tougher and desensitized. And then it's also going to want to help promote the healing cells to come in to take care of that. Let's go ahead and see here. Oopsies. Here we go. Let's play a video here that kind of shows you through what we're looking at as well. So we're taking the laser and we're just going to circumferentially go over the area. We are not touching the tissue with this, okay? We do not touch the tissue. You're hovering over in a defocused manner there. You'll see how the little red light is just coming up. It's barely touching it, and you're going around and you're stopping. You're going around. The patient is not numb for these. That area is awake and they're feeling a warm tingle. When the tingle hurts, they raise their hand and you stop. You give them a little break and you go back over it again, and they feel a warm tingle. When it starts to hurt, they raise their hand and you stop. You do that maybe 2 or 3 times and then you're done, okay? Simple. Here we go. So no topical, no anesthesia for these. You want this to be fully awake. So we want the patient to give us that feedback. That's really important for these. You don't want to over treat the area. So let's walk through a case here. So this is a pretty large size ulcer there. The larger the ulcer, the longer it takes to heal. Normally an ulcer takes 2 weeks to heal for a regular size one. The larger they are, the longer it can take, a month to 2 months maybe. So we're hovering over it in a defocused manner. We're getting, I like to call this poxing. So it kind of gets this little white frosty film over it, which is what the laser bandage is doing for you. And that's the final state of it. Here's another one that we treated here, where we've got an ulcer here that's pretty almost raised at the edge of it. And then we're going over and around the area. And so you don't just treat right over the top of it, you're going around the edges of it as well. Okay. So let's talk about some post-operative care here. So for our ulcers in particular, I do not like to do any Oragel for them. I'm not a big Oragel fan myself at all. So for the majority of my patients, I'm telling them not to use Oragel. I don't want it to burn the area and further irritate it. It may take multiple times to treat that if it's larger. So if it's one of those really big ones, let's say you've got a kid that's has an important band competition and they need to play their instrument. They've got this giant ulcer that's making it really hard to compete in this. And doctor, they practice so much and they're going on Friday and today's Monday. So let's go ahead and get them a treatment today. And I want you to come back again on Wednesday and we'll do another treatment on Wednesday for you. That way that hopefully with those 2 treatments of that larger ulcer, you'll be a lot better by Friday, okay? Normally they resolve within kind of 48 to 72 hours of treating these. Like I said, the larger ones take a little longer. For our kids that are having prolific ones of these where they get them like monthly or multiple ones every quarter, I recommend this L-lysine supplement. I've had some great successes with that. Other things to consider too is if they're doing like a mouth rinse or some weird toothpaste, I recommend a very bland toothpaste and not a lot of mouth rinse for these kids because sometimes that can be a big issue for them. That can be a contributing factor. I know it is for myself. For our mucus seals, fibroma, and verrucas, we're not suturing, like I said. We want to be avoiding spicy seasoned foods, no carbonated beverages. So those tend to be the two main things that I ask them to avoid. Most children don't like a lot of seasoning or spice, and most kids don't drink a lot of carbonated beverages. And I do want to see these kids back, like I said, in 2 weeks. Some parents like to put stuff on it. Well, what can we do? What can we apply on there to help? I like to tell them to put vitamin E oil or even coconut oil. That's a common thing a lot of people have in their kitchen that they can use. And the vitamin E oil you can get in capsules and pop it. And that just kind of helps to keep it lubricated. And also they can eat it and it's not a big deal and it'll promote healing. As I was talking about with recurrence with the warts, if you want to think about a kid that's had one frozen off their finger, it is not uncommon for that to come back. And that's pretty generalized knowledge for most parents. And so we want to make sure that when we're removing these, you're getting good, clean boundaries, like we talked about with the mucus seal and those little fingers, or with the verruca, you're not just cutting it off, you're taking maybe a little bit more tissue around it. You're doing a full excision of the area. And we want to let the parents know that we may see it come back, but it's really rare. So the first 48, it's a pretty good show, but most kids with these report pain only during the first like day or two. It's crazy that those big holes in their lip from the mucus stuff, they really don't hurt that bad. And so I always tell them to start with ibuprofen when they get home, before they go to bed, and first thing the next morning. Those are the 3 times I tell them to give ibuprofen, and then they can alternate with Tylenol if they need to. But I want to make sure they're comfortable. I want to make sure they understand that there is going to be some soreness and tenderness in those areas. But it's crazy that it's really not that long that they feel it, even with those large holes. So let's touch on documentation and billing here. So everybody wants to make sure we're documenting things correctly, and also we get paid for it. So one of the big things is making sure that your staff understands that we have to have good pictures, okay? If we have an undiagnostic picture, you might as well have not wasted the time to take the picture. If we don't have pictures, sometimes insurance will not bill for it. And so they're gonna say, oh no, I didn't see it there. You know, sometimes they are crazy, these insurance companies are. And so we want to make sure that we have good documentation. I love it to show the parents. When you blow this up on the screen, it's hard to argue with that. When you blow this up on the screen, I want them to get a real view. I don't want them not to look at it. I want them to know what it looks like. And then when you show the follow-up picture and they see, oh my gosh, look at where we went. That's amazing, doctor. Their jaw's like open. Oh, I can't believe that. And the child was so comfortable for post-op. So this is a really impactful thing. And we can show patients. I will show them, this is a case that I've done and it looks like this, and this is how it's healed. We want to describe what you're seeing in the notes. It's so important not to take just a picture, but to also describe it. If you've got a little ruler, you can do a measurement with the picture, like I did with that fibroma. We can measure that in millimeters. So we want to describe the circumference of it, or the diameter of it. Is it 4 millimeters in diameter? Is it really tall? So is it 4 millimeters tall by 4 millimeters? So we want to decide the location of it. Like I said, most of the time they're in the buccal vestibule or the buccal mucosa of the lower lip. Sometimes we want to just find where it is in the area of tooth number R. And so that can all help us visually think about where that is. Is it a firm palpation, or is it fluid filled and looks like a bubble? Is it red and inflamed, or does it look like just normal tissue? Does it have those finger-like extensions on it? So we want to be defining and describing what we're seeing there in our documentation. A good history, like I said, with those mucus seals, it's really important to make sure that we're documenting all of those things in our notes of what it looks like. How long has it been there? Are they biting it? Does it hurt? Have they had a trauma? Like I said, mucus seals are mostly trauma related. When we're looking at it from the pathology side of it, we do need to send these off for pathology, okay? The Mucous Seal, the Fibroma, and the Veruca. You cannot formally diagnose that without a pathology report. And so thus it's the standard of care. So you want to make sure you have this packet from a lab handy. You're going to send this off to an oral pathology lab to have the testing done. And you put the specimen directly in this little vial that has formalin in it. It is not water. It's a specific formula of stuff. And most labs will mail this to you and you'll have it handy. You put it in here, write the patient's name on it, put it in the other special little screw on top, and you put like tape over it, drop it in the biohazard bag, then put it in a mailing envelope with a lab slip and send that off to the lab the same day, okay? It's imperative that you have this already in your office before you do the procedure, okay? You can't leave that tissue out to dry and then drop it into formalin. We want to make sure we fill out the lab slip or the prescription for it, where you put your provisional diagnosis of a mucus seal. All that stuff that you described, you want to put in here, and you want to also describe how you removed it. Did you remove it with the erbium all tissue laser, or did you remove it with a scalpel? It makes a difference. Sometimes that can help in their analysis to know how you removed it. You want to put the location, and you want to fill out the patient's information. You want to tell the parent that you're going to do this and to expect perhaps a bill from them, and to let the parents know that they normally send the report to your office, not to them directly. So you want to make sure you follow up with the parent on that too. When you get the pathology report back, it normally has the patient's information. They normally misspell your name, and they normally misspell kind of what you're doing, the BioLace Express Laser, okay? So it's kind of funny that nothing in here is exactly right, but this is the exact report I got. But the important thing is down here under diagnosis. Now you can formally diagnose this as a mucus seal, or a mucus retention phenomenon, as they like to call it. And so this is a very important part to make sure you've uploaded it in the chart and that you relay the information to the parents. When we're coding these out, this is really important. You want to write these down. So this is the code for the dental coding for a D7410 is the excision of a benign lesion less than 1.25 centimeters, which is the vast majority of what we're going to remove. For an ulcer, I like this one. The destruction of a lesion is basically kind of the code for that. This code is normally not picked up by insurance and would just be a cash fee. If I was seeing the patient for multiple treatments of this, they would pay for each treatment that they're coming in for. Okay, this a lot of times is picked up by the insurance there, as seen. For the wrap up, really, it's a simple, straightforward procedure. I would start off with a smaller one, and you can stop referring these out and do them yourselves. Once you see that you can do this, it's really fun to do these. I really, really like to do them. And I talk to people about them. And like I said, I get referrals particularly for them from pediatric dentists that are friends of mine, colleagues of mine. And it's a great added procedure that you probably wouldn't have done before. And you get a great return on the investment there. So it's a great revenue builder there for just additional procedures you can do. Other resources, so where can you learn more about these or learn more information about how to do these or laser procedures you can do? We have the Waterlace Pediatric Dental Academy that we're rolling out at the beginning of next year. So it should be up and going for us. And so I'm really excited about this because it's an educational thing for us as dentists to come to learn from each other and to be able to have more of an interactive educational process there as well. So more information on that can be found at this website. And that pretty much sums up my discussion. My wife and I just got back last month from a trip to Disney in the rain with the kids. So they're in their little car seat poncho type things there. And I also want to mention that the World Clinical Laser Institute is also another really great resource for information about courses and learning. And we also, like I said, you can reach me on Facebook as well. Thank y'all.
Excellent. Thank you, Dr. Curtis. That's a terrific photograph. Hopefully you left a little Disney magic for us visiting here later in December. Yay. And thank you for mentioning the Academy. We are super excited at BioLace and WCLI to gather, some of the best and brightest minds, including Dr. Curtis in pediatric dentistry, and really building an effort around education. peer driven, a lot of clinical exchange, a lot of case reviews, really peers building up peers. And we think that's exciting. And we're having a lot of success with that with some of the other specialties. Hope to see the same thing here with the pediatric dentists. So again, thank you, Dr. Curtis. I do have some questions for you, and I think we got plenty of time to get through them. So why don't I fire you off a couple? Okay. There we go. Let's see. This is from Dr. Bijur. Dr. Curtis, how do you tackle the mucous seal that is submucosal? Wouldn't you rather watch it?
Good question. So if we're thinking about one that is deeper, that's going deeper down into the tissue, I do not like to watch these, okay? There's kind of older literature that's saying that the majority of them do resolve. My question is, what was the population that they looked at? My argument would be that's probably adults that can leave them alone. I myself last year had a mucus seal on my lower lip in November that lasted about a month and almost a half, and I didn't mess with it at all. And I was almost ready to cut it off of there myself when it resolved magically, but I didn't ever mess with it. Kids are gonna chew on that, they're gonna play on that, and it just goes deeper and deeper and deeper. That kind of submucosal, deeper one probably started out as a superficial one and kept busting, popping, and going deeper and deeper and deeper. And that's what I explained to the parents. I'm more than happy to monitor that for them and to take the pictures and document it. And I like them to come back in a month or in 3 months so we can see what it's looking like. And that further helps you in your documentation to justify removing it. I'm fine removing that deeper down. And what you're going to find is, like I said, sometimes those teenagers that really don't talk to the parent too much about it. I had one that had one for over a year and a half that was really, really deep down in there because it had just been growing more roots deeper down. And so that's my fear. The longer you leave that, the more firm and nodular and gnarly that thing would get. So if you didn't feel comfortable removing it, perhaps just monitor for a little bit and see if it is trying to resolve, but also considering referring that out. Great question.
Well, it would probably help if I came off of mute. Sorry about that, Dr. Curtis. And this is from Dr. VIJ. I'm not sure how to pronounce that last name. Forgive me. Hi, Dr. Curtis. Have you used a diode for these types of lesions? I don't know exactly which lesion he might have been referring to because we're looking at it, in a latent fashion here, Dr. Curtis. But how do they work in comparison to the waterlays? So kind of diodes versus waterlays with these lesions.
Yeah, that's a really good question. I love the waterlays because, like I said, the cell layers that it affects, it only affects about 5 to 10 cell layers. With a diode, it depends on what setting that you're setting it on. The diode is more like a really hot paper clip. If you want to think that you heated up the paper clip and you're actually touching the tissue and singeing the tissue with the laser. So you're actually getting a deeper zone of necrosis around those cells. I have some really good PowerPoints of the difference between, or slides that show the difference between what an electrosurge, a diode, and the waterlace I+ does to that. That's in some of my other talks that I do. But it's really interesting to see that zone of necrosis. And so that would be the difference for me, why I love the waterlace more than I love a diode, because it's going to cause less scarring. The more heat that's applied to that, the more necrosis you're going to get, the more risk there's going to be for not that beautiful healing, but for more gnarly, knotted necrosis. Okay. And so I don't like to use the diode for these procedures. Now, if we had sprung a bleeder and hit in a vessel, the diode can be a very effective way to get instant cauterization of that area really quickly. But once again, there's a trade-off to that cauterization. We're going to get a lot more inflammation, a lot more post-operative pain, and a lot more risk for scarring. So you're not going to get the results that as beautifully as you're hoping for, as consistent. Okay, good question.
I was just trying to get my arms around gnarly, knotted. I forgot the third part, but great alliteration there, doctor. So the next couple of questions are similar, and they're really about charging or fees. I'll kind of lump them together because it's probably a general answer. But from Dr. Laura, how do you charge for ulcer treatment? And from Dr. Lee, how much do you charge for removal of a mucus seal?
Good question. Let me come back here to this area. So it can kind of depend on your insurance reimbursements, to be honest. So what your in-contract price is for these. Normally for this procedure, for the ulcer, like I said, it's not a covered. So we normally do like a $95 visit. Okay, so it's $95 for us to treat this. So if you're coming in for 2 treatments, you're going to pay $95 each time you come in. Okay. For the Mucocell removal, I think the charge, I can't remember exactly off the top of my head, is going to be in the upper like 290 to like 350, I believe. I think some insurances that we're in network with may cover it a little bit higher, but that's kind of the range, kind of we could say around 300, give a little or a little bit more. So maybe upper into the 400s, depending on kind of where you are, but that would be the reimbursement rate. So for a simple 5-minute procedure, that it's a really, really great product or a great return there for you on that. And it's really rewarding too. So good
Sure.
question.
Thank you, doctor. I think we probably have time for a couple more. And I apologize, I'll say Dr. Shashank because I know I won't do justice to his last name. What is the best time to treat ulcers from the time when it started? And then I think you've covered the coding and charging for it, but more, when would you get after an ulcer if, under ideal conditions here?
I would love to get it as soon as I could, to be honest. So if they're coming in, they're like, this is just started, then I would want to get to it soon. I've had one patient in my practice that had gotten them a lot. And so we've been talking to the mom. The next time he comes in, or the next time he gets one, I want you to call us and we'll bring him in. And we had already noted it on its chart. Like we didn't have anything treatment planned for him just yet. Or you could go ahead and treatment plan it and just leave it hanging out there, knowing that you're probably going to get a call for it. You could handle it that way. Or you could put a note in the chart that this will be the treatment plan if the parent calls in. That way your lady on the phone or your staff member would be able to help them more directly with that. And so that tends to be kind of the way we would handle those, is trying to get to them as soon as we can. If it's one that's come to you as like a limited exam saying, oh, this has been hurting for like a week. If it's been more than a week, a lot of times I'm like, did you want to pay to get it done and see if that helps you? I mean, you're paying, I can't feel what you're feeling. But sometimes if you're on the back end of it, it'll resolve in a couple of days, where the laser is going to help it resolve maybe a day sooner or a couple of days sooner. So is that worth it to your patient or not? So just helping them work through that choice of that. But that tends to be how that works. If we can get to it the sooner, that's going to be the better. Good
Sure.
question.
And maybe the last question then, Dr. Curtis, and there isn't a name associated with this one, I apologize. But it's more about, I think, specific to waterlays. Can you use the laser bandaging or do you use laser bandaging or the laser desensitization settings? Sorry, say that 3 times fast.
Good question. So I do like to use the laser bandage after I'm finished with any procedure, like soft tissue wise, just to help get a little bit more hemostasis in the area. If you get a little site of bleeding from just one little area, it can really help to get a little bit more of the coagulation from that. But I like to go over it from that. As far as the desensitization with that, honestly, the diode laser has a much deeper depth of penetration than the water laser is going to have. So you're going to get a lot more of the numbness from doing a low level laser therapy with the diode than you're going to get with the water laser. The reason the water laser is really effective in, let's say, hard tissue, so doing a filling without having to numb, is that it's working at a much smaller level. And so it's desensitizing smaller. So you're way less likely to actually numb the entire tooth. That's not what you're doing, where you could potentially do that a lot better with a diode because it's going to have a deeper penetration. And so I don't really utilize a lot of desensitizing, if you will, with the I plus, just because the mechanism that I use it and how I utilize it, I'm really not needing to do any sort of things like that because of how I'm utilizing it. Good
Right.
question.
Excellent. I think that's all we have time for in terms of questions, Dr. Curtis. And as always, you finished right on time. Thank you so much.